think we're here today to try and inform as many veterans as we can. We're here with Dr. Bash.
Welcome, Radio Land, TV Land, and YouTube viewers and listeners. This is Dr. Craig Bash. I've been doing veterans medical opinions for 30 years, and I have dozens and dozens of these radio shows which we're going to publish on this YouTube channel, and number 1 through whatever. So thank you for listening, and here we go.
I often found that because I was dealing with so many MS cases, multiple sclerosis. MS presents frequently in patients with very fleeting symptoms. And they'll go away. And they may or may not be severe. So a patient might experience one day a sudden onset of a numb left foot. And it's aggravating to him, but, you know, he doesn't complain about it. He goes to work and everything else, and then it gets better. So he just, oh, hell with it. And then he doesn't realize until somebody with medical knowledge points out that, hey, that's consistent with the presentation of MS unless there's something else to explain it. Okay? Now, one episode may or may not be persuasive, but if he has this lay history and he is now recalling he had a symptom affecting a hand in 1 year. A year later, he had a symptom affecting the foot. Another time, he had a blurry vision erupt in an eye, and then it cleared up. Now you have a pattern of symptoms, and that contributed to the effort of determining when the disease process began presenting symptoms.
Hey, Bill, on MRI, oftentimes I look at those. The MS lesion will be like a halo, and the new inflammation will start in different aspects of the halo. So even the person might have a hand symptom this month, and then it goes away for a year, and then the hand symptom comes back again in a different part of the hand. So it can be even in the same part of the body, repetitive.
Yeah, or a different part or the same. That can come up too. Yeah, absolutely. And seen plenty of cases like that. And that is. We've had so much success because you take and you look at these symptoms, and with knowledge of presentations, potential presentations of MS, and the absence of any other particular disease or injury to explain the symptom, it helps in establishing the diagnosis and establishing when it had its onset.
Hey, Billy, want to explain that 7-year rule since you're on MS?
Sure. The rules, the law provides that if MS presents within 7 years of your last period of active duty, that it's presumed to be service-connected. So it's a 7-year window. Now, I've helped correct mistakes by raters who have said service connection for MS is denied because it was not diagnosed within 7 years of service. Wrong question. Wrong answer. It doesn't matter when it's diagnosed. It's when it presents. When does it become symptomatic? Okay? That determines whether or not presumptive service connection apply. Now with MS, the minimum rating is 30%. Okay, so for presumptive service connection, your claim disability has to manifest to a compensable degree in order to be granted presumptive service connection. But the minimum rating for MS is 30%. Any manifestation of MS gets you no less than a 30% evaluation, so you satisfy the requirement of presenting a compensable disability.
So, Bill, we have people with symptoms in 7 years, and then the MS goes quiet for a decade, and they get diagnosed 17 years after service. In that case, they get granted all the way back.
Well, no, because you have to have the diagnosis. Okay, so if you filed the claim and you were denied for some reason, I'm not sure why. And later, decades later, you come up with a presentation of symptoms and a diagnosis of MS. And now you get an opinion and say, hey, this MS manifested within 7 years. Now that's new evidence. So you have new material evidence. Excuse me, that's an old term. New and relevant evidence is the new term that might lead to a grant. You reopen the claim. So that's new evidence, new relevant evidence, and you reopen the claim. And the effective date is as of when you open up. Now,
what I was trying to say is that the symptoms were prior. Yeah. Right, Bill.
You have to have both the symptoms and a claim. Okay.
Right.
And you have to have a diagnosis. And at the time of the original claim, you have to have a diagnosis. It has to be diagnosed then. If it wasn't diagnosed then, you made a claim and you were denied because you don't have a diagnosis, then you lose. But sometimes, and I'll tell you, I have been responsible for having raters reverse denials and for having reverse denials myself because it used that boilerplate language. You're denied because MS was not diagnosed within 7 years of service. And I said, that's wrong. Clear and unmistakable error because you used the wrong law. There was a diagnosis, okay? It wasn't made in the 7-year period, but you applied the wrong test because it doesn't have to be. Ergo, you were wrong. Symptoms were manifested within 7 years. CUE, and it goes back to when it was denied first time.
Yeah.
Takes a doctor knows what they're doing to be able to say that.
Sometimes you use the MRI too, like these lesions come and go to certain frequencies. So if I see a bunch of lesions, I can roll the diagnosis back a while because the lesions don't just occur instantaneously, you know. So the imaging can have an important part in this whole process.
Yeah. 8 o'clock already. Are we still on the air?
Yeah, one more time, guys. Go keep on going.
So Dr. Bash, just Google on Craig Bash. You'll find me. Find my little YouTube stuff, or call Skip 925-381-7561 for a phone. 925-381-7561. And Bill consults with me so we can get both of us.
Yeah, Dr. Bash will call on me on the cases where he thinks that can be used.
Well, that sounds good. That was a good show.
We did well.
Yeah, we got a lot of information out there, that's for sure. And I'm certain that the Coast Guard people out there listening, or someone that knows anyone that was in the Coast Guard, be sure to let them know that if they end up with some medical issues, they could be pinned down to exposure to lead or red lead or asbestos. Be sure to let them know that there's a way for them to get themselves taken care of.
Mm-hmm. It's true, Joe. Exactly. Let me give a battle point up before we close the show. People that are doing claims and adjudicating claims and filing claims, if you claim a condition or you claim something that you were exposed to in the job you did while you were in service, especially within the Navy, it's always good for the first thing to pull out of the record. Not your medical record, but the most important thing is to find out exactly what you did in service. And people, after time, your memory fades a lot. So if you go through your record, you fill out each one of your enlisted performance evaluations or service evaluations. Look on the back page of that evaluation. Each one of them gives a detailed list of what you did while you were in service assigned to certain jobs. So that makes it a lot easier for people to find out what they did and what they were exposed to.
Hey, Bill, the rater looks at that too, right? Because if the job is consistent with the exposure or the risk, then that helps consistency, right, Bill?
That's right. The statutory language is consistent with circumstance, place, and type of service. Right. And so if what you say is consistent with history shown in your duty assignment, that supports your claim.
Especially if you, asbestos claims, stuff like that. Somebody says they removed asbestos, and you can look in the back of that sheet, and you can just about, you can see in radiation claim the same way because it tells you where you did the work at. So.
Right. It's pretty. A lot of documentation on that.
That's a smoke.
I feel for those guys back a long time ago with the early radiation experiments whose documentation wasn't made really clearly. A lot of experiments a long time ago.
Was it Operation Crossroads? They dropped that. They dropped the air nuke and they let the guys go back.
Crossroads.
After a couple of
Crossroads was actually tests in the islands in the Pacific. Blowing up ships in the lagoon and stuff.
That was in Bikini Atoll. It was Bikini as that area.
Yeah, Bikini Atoll. Yeah.
Yeah, that was Able
and that
Baker
was
blast.
a series of explosions. I saw and I also saw a report from the General Accounting Office some years back that said the dosimetry on the cruise was grossly underestimated. That if your dosimetry record showed exposure to 1 rem, it was more likely 5. And
there's a lot of problems with dosimetry. I've looked at some of those badges, and it's supposed to be a cumulative dose, and sometimes the dose gets smaller and higher in the cumulative column. That doesn't work like that. Cumulative dose is a cumulative dose. Back to the concussion TBI stuff, I always ask my patients where they worked, and I had a guy that had TBI. I said, "Did you ever have TBI?" "No, I never had TBI." "Where'd you work?" I sat under the front gun of some Navy ship and had thousands and thousands of rounds go off. And I said, it's probably TBI. Pugilistic of it. Where people work is a big deal, and they don't understand necessarily what the exposures are,
Concussion TBI.
Yep.
Concussion
TBI. Little blast.
Yeah.
I couldn't imagine being around one of them big guns. That'd be rough.
Oh yeah.
I got a guy.
A couple fellas that. I know a couple fellas with hearing losses and tinnitus associated with those big guns.
TBI should be special.
I remember. Oh God, I hate to digress, but I remember this one case. It's just as silly as can be. The guy is receiving compensation for his hearing loss and his tinnitus based on documentation showing that he was near a big gun when it went off, when his ship was exchanging gunfire with an enemy battery in Vietnam. Okay, so the Vietnamese were shooting at them and they were shooting back, and this guy, his service connected for his hearing loss and tinnitus incurred in combat. Okay? They denied his PTSD absence of stress. Come on. My decision was, here's your check.
It's a low ball rating.
Yeah, that's low-hanging fruit there.
Kind of reminds me of a fellow got service connected for exposure to mustard gas on his ears and got turned down to the rest of the exposures.
That's unreal.
We know that guy. It is what it is, people.
And we just keep focusing on the truth, getting the documents we can, putting together the case as tight as we can make it. Who was it? Dorothy Hamill used to say, "If you're good enough, they got to give it to you."
Eventually.
Yeah,
I know. But I
Keep
tell
plugging
you,
until it hits the right desk.
You got to ask a lot of questions.
reasons.
You got to ask a lot of questions along the way, because those 15-minute medical visits or those, top sheeting records doesn't really get the data we need, right, Bill? Got to dig in and find the details.
That's right. Details. When I was working for the Maryland Veterans Committee, I was the supervisor of appeals for the state of Maryland, and I made up a little survey, kind of a little check-in and check-out sheet. And I told all my veterans, when they go down to the clinic for their exam, you got to stop in my office first. And I'd give them that sheet. And I said, now you're going to take this down with you, and you're going to take it with you into the exam room with the doctor, with the examiner. You're going to sit down at his desk, you're going to pull out your pen, and you're going to write down the time right on the top of it. Okay? And you're going to do the same thing when you check out. When the doctor dismisses you, you're going to write down the time. And you're going to bring that back to me when the exam's over with. And then if the doctor asks you what you're doing, you say, I don't know, the guy there in the state of Maryland told me to bring this back to him when it's over. Guess what? The exam time started increasing dramatically.
Well, it should.
Yeah.
It's a mess now. I mean, you go to the VA and see the VA doctor now, and they go to your appointment. The VA doctor's in front of the computer typing up. He might look at you for about 10 seconds during a 15-minute meeting.
Yeah.
And then, so it's, they've taken away their help and everything else. The doctors are one-man gangs. I even had a doctor the other day. The doctor was going out into to the weight room getting patients and taking them back.
Well, now, while we're on the topic, I got to say, I had my last CP exam. I was very impressed. He had read the record before I came in. He fully discussed everything with me and all the possibilities and variables, and conducted the range of motion. Not a little off on that, but hey, it doesn't make any difference. It's a shoulder, 20%.
Yeah.
The only rating you can get.
I know.
So, I was very impressed. And I was grateful
how much
for the
range
time
of
we spent with him.
How much range did you lose, Bill, after you had your surgery? Did you lose a lot?
We were talking. The exam was before the surgery.
Yeah. Okay.
And the exam was before the surgery, and I could forward flex to maybe 80 degrees.
Right.
I got that far. This hurt too much. Wouldn't do it.
Yeah, I know. I know exactly what you're saying. I'm going through it right now myself, so it's bad.
Yeah. So he recorded it 110 degrees.
Really?
I don't know how I got that, and I don't care. I got his 20% anyway.
I think Bill Cleveland going through a C&P exam would be like Babe Ruth walked into a baseball clinic. Yep.
They had an empty seat in this one training event one time when I'm VA employee, and they had this one seat empty, and they needed to fill it, So they said, Bill, you go. Okay, sure, I don't mind. They got the section there. Now they're going to teach the raters how to rate muscles, okay? And the poor fellow they had doing that, he was just giving it as a thank you for, a chance to travel a little bit and have some meals on the government and see some local geography and culture and stuff, So it was like a vacation for him, He was so lost. And, I'm very politely and gently trying to help the poor guy. And it didn't take long. He said, Bill, would you come up here and finish this? I've done this 100 times.
Been there, done that.
Yeah, so much. Yeah, I've run into that a bit. Yeah, because I take the time to read and learn, okay? And you can't do that when you're on a quota. So, I had a big advantage when I went to work for VA because I had already studied so much and made a point of learning so much compared to the classmates who, are being introduced to this. So I was able to maintain, being one of the most productive raters on the office and still have time to write up lengthy and comprehensive decisions. The folks over in the quality review staff are saying, Phil, you're just writing too much. He says, a veteran isn't going to understand all that. And I said, I'm not writing to the veteran. I'm writing to you. You're the quality review. Hopefully you'll learn something.
I think the VA needs more quality review personnel myself.
Well, no, they've actually dumbed it down. The process changed, from trying to understand the law and the medicine involved to transfer the data off the exam into the computer, and the computer tells you what to do.
Yep.
And you're required to use the computer to do it. And like I was talking with Gerald earlier today, let's say you've got the case where you're evaluating somebody's PTSD.
Mm-hmm.
So the VA examiner checks certain boxes on the DVQ and says, okay, there's depression, there's, sleep disturbance, there's alteration of mood, et cetera, et cetera, et cetera. Well, okay, and then the doctor also says, well, there's nightmares, flashbacks, intrusive recollections, psychophysiological reactions triggered by events that remind him of the event. Okay, so there's a whole set of other symptoms that are typical for PTSD that are not in the rating schedule. Okay? So if you transfer the data over, let's say the computer tells you it's 50%, you're required to assign 50%. Unless you choose to click it 1 up to 70 or 1 down to 30. You have that option, but you're also instructed that every time you do it, it's going to be reviewed by central office. And nobody wants their work reviewed by central office because they're going to go through that file end to end and try to find something they can nail you with. So nobody wants their work in central office because nobody wants it reviewed because central office is going to come back and find something wrong with it. And when you're doing 4 cases a day, you probably type something wrong in every last one of them. So nobody clicks up. They just do what the computer tells them to do. Well, I made a point of clicking up frequently, particularly in PTSD cases, and I cite to Mallerham, where the court says you have to consider all the symptoms, not just the ones listed in the rating schedule. And so I say, with consideration of those other symptoms from PTSD, the disability picture more nearly approximates 70%. Never once was I ever challenged. Not once. Nobody ever asked me to reduce that rate. And so either they didn't review it, which is a possibility, or they understood it and agreed with it. So I wish
Bill,
other people had the courage to do it.
This idea of migrating towards the mean, getting rid of the outliers is a big problem throughout all of medicine because of the electronic record, So in the clinics, there's not range or places for the gray zones to be described, and so it messes with the diagnosis. And doctors are getting called in like from malpractice, and they say, well, I was thinking this, but they say your electronic record said you thought that. And so it really causes a lot of problems throughout the whole system because it's cookie cuttering the whole thought process into little squares and boxes you check.
Yeah, it's a similar trend. Yeah, I can see that.
Well, don't that you know, this digital stuff is still relatively new, and it depends on the programmer who in the world wrote up these programs. Until they get that correct, I think you're going to see problems here and there, and probably more often than not.
Gerald, you're right about that.
You're right.
It depends on the audience, Gerald. You're right. So, like the electronic medical record in the hospital is all written so that the insurance companies could do billing, and the DNQs were all written so that the VA can do ratings. And so it depends on the audience who paid for the programs. They're going to get what they want out of them, and the rest of the stuff is going to go by the wayside. You're right.
Yeah, I agree. I think that's and that's going to be problematic till they get the bugs all worked out of it, and no telling how long that's going to take, because especially the VA, I don't see any reason for them to want everything to be a notch higher.
Well, the DBQ process. Yeah, the insurance, it's like insurance companies in a way, yeah. The DBQ process is a work in process. And there's a continual process of reviewing them and amending them to try to adapt to the needs of the adjudicators, the raters, so that they can make it easier for the rater by saying, okay, this is what that. You know, but, I was one of those. I was one of what the central office used to call crusty old grows.
Crusty, there you go. Crusty crab.
Crusty old grow.
Yeah.
My biggest fear with that system is once the
Thank you all for listening. That ends this show. And now I'm going to zoom off.